I'd like to begin by acknowledging the traditional owners of the land and paying my respects to elders past and present and emerging. I also acknowledge the stolen generations and their families. So just to give you a bit of a background on the Let's Chat Dementia project, in this study, the aims are to increase detection rates of cognitive impairment and dementia by raising health service and community awareness of cognitive impairment and dementia, and health service knowledge about skills for preventing, detecting and managing cognitive impairment and dementia, and to optimise care for people with cognitive impairment and dementia, their carers and their families. As a part of our study, we have developed a best practice guide for Aboriginal and Torres Strait Islander people attending primary care. These workshops are based on the content of the guide. Webinar 3 today is on healthcare for people living with cognitive impairment and dementia. You can see that in blue here on the slide. In the last webinar, presented by Professor Mark Wenatong and Professor Eddie Strivens, we talked about the detection process for cognitive impairment and dementia. Let's just recap on that to refresh our memories. The big focus of our study is to get everyone thinking more about brain health, being aware of the risk factors, following up on any concerns you might have, also being proactive and asking patients questions about their brain health and knowing how to proceed if you are concerned about somebody. And at the end of this webinar, you should be able to describe best practice clinical and cultural aspects of care for Aboriginal and Torres Strait Islander peoples who have been diagnosed with dementia, learn about the progression of dementia, learn about the general and dementia-specific healthcare needs of a person living with dementia, and how to incorporate support for these needs into everyday care management. Understand the importance of a coordinated and holistic case management approach to the care of a person living with dementia. These are the principles of care that the guide recommends. Healthcare should always be culturally appropriate. In Aboriginal and Torres Strait Islander communities, this means that care needs to be family-centred as well as person-centred and trauma-informed. Dementia is a chronic condition and there is no cure. It is a progressive and eventually terminal. These features support an overall approach that should aim to optimise quality of life, maintain function, and maximise comfort throughout the disease trajectory. Dementia care is complex. Many different members of the healthcare team need to be involved to provide comprehensive care. It is important that a person with dementia has regular reviews because their care needs will change as the condition progresses. And finally, care for the person with dementia involves primary health care and also care in the form of social and support services. This is a poster that summarises the main areas of focus in the best practice guide. Today, we are living with dementia and more specifically healthcare, focusing on living with dementia and more specifically healthcare. There are different ways of categorising the progression of cognitive impairment and dementia. Dementia is often talked about as having several stages. We will talk about mild cognitive impairment, plus 3 stages, early, mid, and late stage dementia. Dementia doesn't affect everybody in the same way, affects different parts of the brain at different times. So these stages are a guide only, and people have good days and bad days. Also, different types of dementia present differently. For example, in Alzheimer's disease, memory loss is a common early symptom. In vascular cognitive impairment, mood changes and mobility problems can be an issue. And people living with Lewy bodies dementia often have episodes of confusion and visual hallucinations. This is because different parts of the brain are being affected. Now we'll have a look at the different stages of cognitive impairment and dementia. In early stages, when a person has mild cognitive impairment, it can be tricky to recognise and diagnose. The person is still able to function fairly normally, but there are definite cognitive changes on testing. In early dementia, the person's life starts to be affected more and they aren't able to perform more complex tasks as well as they used to. When a person progresses to mid-stage dementia, they start to become more affected physically and their functional abilities decline further. We often also talk about responsive behaviours in dementia, also called behavioural psychological symptoms of dementia, or BPSD. These start early in dementia and become more pronounced in the mid-stage. Dina will discuss BPSD in more detail a little later. In late-stage dementia, the person needs assistance with most things, even very basic functions. They may also lose their ability to speak. So let's look at a case study that was initially discussed in the last webinar. Auntie Molly is a 68-year-old woman who lives with her son, Frank. Frank took Molly to see Karen, the local health worker, due to concerns about Molly's memory and behaviour. Karen performed a kicker screen and Molly got a score of 18 out of 25. Molly was further assessed by the GP and was referred to see a geriatrician for a specialist assessment. The diagnosis of early stage Alzheimer's disease was made. Frank visits the health service to speak with Karen as he is worried that he does not know how to look after Auntie Molly properly, now that she has been diagnosed with dementia. Frank tells Karen that Molly seems more forgetful and is doing strange things like putting the empty milk cartons in the microwave. He also says he found stained underwear and unwashed clothes in, which is unusual for her, and she is accusing him of stealing things. Frank says, "I'm worried that Mum's dementia will get worse. How do I get her to keep doing the things that she can do for herself? I haven't got time to do everything for her as I have to look after my kids." And now I'll hand you over to Dina, who will talk to us more in detail about healthcare needs of the person with dementia. Thank you. Thanks, Dina.
Thanks, Harry. So the next number of slides is really aimed at describing healthcare issues. And as I mentioned before, the focus is primarily for Aboriginal primary healthcare services, but any healthcare services that are assessing and managing people, Aboriginal and Torres Strait Islander people, in their care of dementia. So it is more of a healthcare focus as compared to some of our other webinars. So as Harry mentioned, dementia is a chronic progressive condition, and as a result, there are different stages and the approach needs to be different for each area to optimise quality of life, maintain function and maximise comfort, using a family-centred approach, but also a trauma-informed approach. As Harry mentioned, mild cognitive impairment is a sort of tricky stage. It's where someone, it may be symptomatic of a dementia or an early emerging dementia, but it might be a result of other conditions such as depression or stroke or other aspects or other conditions, particularly comorbid conditions. But it's a really important stage, and that's why the study, we're really keen to encourage people to look for memory and thinking problems early on, because we know that there are things that can be done to help prevent ongoing decline and to optimise function, and as we've said before. So not all mild cognitive impairment will go on to develop dementia, but a certain number will. So with, as part of a healthcare service or primary healthcare service, there are a number of things that can be addressed in a holistic manner at this stage and are very important. So of course, the usual healthy lifestyle factors that we know are important and which primary care are really good at. So looking at diet, talking about smoking, physical activity, safe alcohol, etc. As we know, many Aboriginal and Torres Strait Islander people have lots of other comorbid conditions, particularly hypertension, diabetes, heart disease, that could also contribute to cognitive impairment. And so it's really important to manage these appropriately as well. And we'll talk about each of these stages a little bit later on. We know that hearing impairment is now a very important, so it has a very important association with dementia. And if we can optimise hearing early on so that the older person gets used to their hearing aids or whatever they need early on, it's really important to establish that before they have difficulties at the later stages of dementia. Then, as Harry said, of course, there are different stages of dementia and the needs might be different. So if the person does progress from mild cognitive impairment to dementia, the aim is really to try and slow down progression, or what we call secondary prevention. So all those things I mentioned earlier on are really important. So it's sort of like this cyclical review of the person with this condition. And also addressing social and emotional well-being, which can be a really significant factor in a person with dementia. But of course, as dementia becomes more obvious, as it has with Auntie Molly, family members need to be involved and want to know and want to be given clear and accurate information about the diagnosis, about the prognosis, and what's available to support them as they progress through their dementia. As things progress, the person will need more support with regards to their functional needs, either personal activities of daily living. So Molly was showing signs of incontinence that she seemed not to be able to manage. She might have having difficulties within the kitchen, putting milk in the microwave, and also having some behavioural and psychological symptoms of dementia with delusions, thinking that families were taking things from her. So this is particularly a stage where carer and family need more support. And in other webinars that will be presented in the near future, we will be focusing particularly on carer support and also end-of-life care as well. And I guess an important aspect throughout all of this is to talk about decision-making, think about decision-making capacity, but advanced care planning. What are the needs? What would this person want for their future care, including end-of-life care? Oh, what's happening here? Oh, there we go. So I won't focus on this slide very much, but it's really just to say that these are the 6 areas that we'll focus on. And you can see in the resources that you'll be given or that you can access easily through links is that we've developed some GP management care plans that look at these specific areas as they relate to dementia in Aboriginal and Torres Strait Islander people. So first of all, if we look at general medical care, so of course, within primary healthcare settings, there's the usual business of thinking about immunisations, treating acute problems like UTIs or chest infections, reviewing medications, etc., and addressing acute problems as they arise. Other aspects that are important are addressing social and emotional well-being. And we know that people with dementia, that depression and anxiety can be quite commonly occur, and can actually occur quite early as part of a mild cognitive impairment. and can cause distress to the person and their family as well. As mentioned before, Aboriginal and Torres Strait Islander peoples have significant comorbidities, and we know that people with dementia, so for instance, 60% of people with Alzheimer's disease will have 3 or more comorbidities in the general population, and this may be more for this population. So things like hypertension, diabetes, chronic renal disease, anemia, depression, etc. Another really important aspect that we need to think about and is often forgotten in dementia care is oral and dental care. We know that nutrition is a big factor in dementia, and we know that about 10% of people will lose up to about 10% of their body weight even before the diagnosis is made. Poor nutrition will lead to muscle loss, pressure areas, etc. So it's important early on, again, before the person develops dementia and it's harder for them to engage with dental care, etc., that we address that early on. Things like dry mouth might relate to medications, poor fitting dentures with change in weight, etc., needs to be reviewed. And medications needs to be reviewed again and again and again and again. So looking at medications that might contribute to confusion, particularly those that have anticholinergic side effects, or those that analgesics that might cause confusion with opioids or sedatives as well. So people get put on medications and remain on them long term. And we know, particularly as the person becomes more cognitively frail, that those medications can then lead to falls and other adverse events for that person. And throughout the course of cognitive impairment and dementia, it's important that we encourage physical activity and social connections and cognitive activity. So things that makes the person feel engaged with their community, ways to try and include, optimise physical activity, being engaged with maybe some of the social services that are often linked to the primary health care services. Oops-a-daisy. So in, say, Auntie Molly's case, or in a situation like this where there may be quite a lot of things going on, and as we know, the care for people with dementia can be complex, a case conference is often a very good idea and can be called to try and address the many issues that have been raised by Molly's son, Frank, and also picked up by various of the health services. And we'll go through that. And of course, with each of these suggestions or referrals, etc., that there are MBS items that can also be claimed, and so keeping the administrators happy as well. So if we look at the involvement of who can be involved in the care of someone with dementia within the primary care health service, well, it's really everyone's business. So everyone can be involved in different ways. From the administrator or the receptionist at the desk, making sure that reminders are sent out, or organising a taxi to pick up Auntie Molly or other people, all the way through to the various different health service providers. And in this setting, of course, the Aboriginal health practitioner has a vital role. They are often the first person to pick up that something's not quite right, and will have the link with the community and with the carers and families when things start to be obvious. And we know that best practice is that a case management approach is important, and with every service will have a different way of doing that. But to have particularly one person that frank as the primary carer can contact when he's not sure what's going on or needs some support, well, obviously that needs to be addressed early on. Other people involved in the care of someone with dementia are obviously diabetes nurses or educators, or to make sure that the person, as their needs change or may not manage their diabetes as before, is managed in an appropriate way, particularly to prevent hypoglycemic attacks. And we know that as a person with dementia might, who used to previously manage their diabetes well, and if you find that they're not now, it may be a result of their cognitive impairment. And that can result in multiple admissions to hospital, etc. The pharmacist, that often is in-house or with a local connection, is very important for reviewing the medications, as I've mentioned before, and looking at interactions. And as people get older, metabolism is different, and so the side effects may change over time, or the effectiveness of the medications may change over time. Physiotherapists are essential for encouraging exercise, but also minimising falls and maximising mobility. The occupational therapist in doing a home visit to see, look at safety issues, particularly around cooking, falls, etc. And as you can see there, checking for hearing, checking for vision, implementing new glasses or hearing aids as early as possible, the dietitian for supplementation of nutrition, and of course, psychology, social work and counselling play a really vital role for the person themselves, and also for the rest of their family. And in certain areas, of course, the traditional healers may be required or may be sought after. And together, I know particularly in the Kimberley, where I've been involved in the past, that often people would want to engage a traditional healer, and working with that person is also important. As we've mentioned before, that there's different stages that people go through, that at all times, that in a regular fashion, we have to review cognition to see how things change, how things progress. Some people with dementia seem to progress very quickly, others more slowly over time. And of course, you can't sort of hit everyone with all the different things that you need to. It's about regular yarning, checking in, starting to sort of plant the seed of various things that are required for the future. Decision making is obviously important, and we all encourage thinking about powers of attorney or future planning very early on while the person has capacity to do that. Looking at financial management, safety, which I've mentioned before, and also all the functional aspects of things, such as in the home environment, and also medications, cooking, etc., and also driving. So in many of the states that a diagnosis of dementia requires that the person reports that, or the practitioner reports that to the local driving authority. So in Victoria, where I am, it's called Vic Roads, and it'll be different for different areas. And these are all, very hard discussions and complex discussions to make. So it needs to be addressed sensitively over time. And now with dementia, there's also a particular risk assessments that need to be addressed, which we do in older people generally, but with particular focus in those with dementia. As I've mentioned, nutrition and hydration, so I won't speak about that again. But we know that chronic pain is common in older people, and also in Aboriginal and Torres Strait Islander people. In a study in the Kimberley, we found that 64% of people over the age of 45 had pain, and it was rated as severe in almost half. But as people with developed dementia, they may not be able to express that, and it's very important because it may be expressed as agitation, depression, etc. Falls are common, particularly twice as common in people with dementia, and fractures, unfortunately, is 3 times as common in people with dementia as those without. There's numerous factors, might be postural blood pressure. So so for a nurse involved in the care, apart from doing blood pressure, it's always good at different times to test for any postural drop, to review the medications that might increase the risk of falls, particularly sedatives like benzodiazepines, check vision and all those sort of things that I mentioned before. Incontinence, so Auntie Molly we saw is having problems with continence issues, and again that can be underreported. It may be a previous problem that is now not able to be managed as her dementia progresses, or it might be particular medications that might be making it worse. So, for instance, the cholinesterase inhibitor that's used for dementia can make incontinence worse. So think about ways to address that, thinking about brainstorming with the service and family members how to approach that, and a continence referral to a local continence service could be really useful for that. And of course, unfortunately, it's all too common that elder abuse might be an issue, which can occur obviously as people get older, but particularly for vulnerable people as they develop dementia. And I guess no one really likes approaching this topic, but it's really important to be aware of it. And again, that's where the whole health service keeps their eyes out to see what's happening, and can be particularly picked up in a home visit type environment. Elder abuse can be physical, financial, psychological, or neglect, and needs to be addressed. In one of our further seminars, future seminars, it will be also discussed in a little bit more detail. And then finally, with regards to behavioural and psychological symptoms of depression that Harry touched on, as dementia progresses, we know that this occurs in most people with dementia at some stage. It goes through cycles, so it might be, so agitation might be prominent for some stage, but not later down the track. It can be also thought about as responsive behaviours. So most of these behaviours really are unmet needs, a response to unmet needs. But the definition is a symptom of disturbed perception, thought, content, or mood. And you can, with Auntie Molly, she was feeling that family were taking her money. So that could be part of a delusion or a psychotic sort of manifestation. And just to show you some of the groupings of BPSD, and I know if people are familiar with dementia that that you would be familiar with these, but again, just to think about hallucinations and delusions that are more prominent, particularly with someone with Lewy body. We spoke about social and emotional well-being and depression, and thinking about that, understanding that a significant proportion of older people will have been part of the stolen generation. And so as their cognition declines, it may lead to triggers or memories from the past that really need to be considered thoughtfully and sensitively, and that's why we've mentioned that one of the principles of care really is trauma-informed care in addressing all Aboriginal and Torres Strait Islander people of a certain age. As a visiting geriatrician at one of the Aboriginal health services in Melbourne, almost every person I see over the age of 50 will be touched by the stolen generation, and many have depression and anxiety. With dementia, we know that apathy is very important as well, often not picked up, but very common, particularly in Alzheimer's disease, and can be difficult to differentiate, obviously, from depression, where the person's withdrawn, they don't want to do anything, they don't want to go for a walk, they don't want to exercise, they don't want to engage with anything, anyone, and can be very stressful for carers. We all know people where there's aggressive behaviours, both either verbal or physical. And of course, people can just be agitated. They want to go to their old house, even though they're in their old house. They might want to wander or follow you around. They might say things that are inappropriate and have repetitive actions. You know, for instance, packing up their bags because they want to leave home. So these are all the different aspects of behavioural and psychological symptoms of dementia. So as I mentioned before, they often relate to unmet need, and with all people with dementia may be triggered by pain or a change of environment, change in medication, an acute condition, etc., and needs to be addressed. And services like Dementia Support Australia or Dementia Australia can help the person and particularly the carer manage some of these conditions. And then lastly, when we think about referrals, again, it's a multidisciplinary approach. So Auntie Molly had already been referred to the local geriatrician and a diagnosis of dementia was made. Could be a memory clinic, might be a psychogeriatric service or psychogeriatrician, but it is best practice guidelines state that if someone has cognitive impairment, that they should have a full and comprehensive geriatric assessment to make an accurate diagnosis and to give advice about general care and medications. Other referrals, so of course we spoke about the referrals within the health service, but outside it might be nursing services for medication management or other care at home, wound management, etc., diabetic care, continence care is continence referrals are very important. We know when we think of palliative care, even though it's changing now, the way that we think about palliative care in dementia, used to be that palliative care was really for people with cancer where they would deteriorate very quickly. But we know with dementia that there's sort of a dwindling progression, and it may be that palliative care services are very appropriate at the end of their life and can help support the person with this transition at the end of their life. And as I mentioned before, I think our last webinar will actually be addressing end-of-life care. And of course, we really encourage that once a person has had a diagnosis of dementia, that they're referred for a My Aged Care assessment as soon as possible. In the MBS review recently, it used to be that the older health check was at 55 plus, but now it's been brought down to 50 plus to be really in line with My Aged Care, so that cognitive questions have been included in the new MBS review, looking at a health check for older people from 50 plus, so that there can be an immediate referral, so that case management can be instituted early, such as a home care package. And I know that with the department, they're really trying to integrate aged care within the Aboriginal and community controlled health services as much as they can. So just to recap that we need a coordinated case management approach. And I won't go through all of these again, but to respond to complex needs, including medical, social, emotional wellbeing, carers, planning and decision making, regular review, quick and responsive support in acute and crisis situations, and that the family have clear information, who their point of contact is, and knowledge and education around dementia and the associated problems that might be contribute to that. And as I mentioned before, and I won't go through this because they're very busy slides, and we've really spoken about all these issues, is that we've made some sort of mock dementia care plans that can be used in the primary healthcare service, or can be used for other services as well. So just the sort of things to think about, and they're involved, and they'll be available on the website in the slides on the last page, looking at the different referrals, so the different resources. So I won't go into that at this stage. So just to finish up before we go into questions, that the goals of care are to optimise quality of life, maintain function and maximise comfort, to look at optimising dementia care within the primary healthcare service. So that might be general primary healthcare, but also dementia-specific care, using a coordinated case management approach. And lastly, as I mentioned on the last page, there are a number of resources that you're very welcome to look at, and we hope that you find useful, and you can always contact us if you do have any questions.